All right, thank you, doctors. And what can you tell us about the Rutgers Center?
Okay, well, we started back in 1994, and it started with Dr. Stone and Dr. Kroll, who brought their private practice into the dental school, and they were seeing a complex population as well, very much similar to what we're seeing at the dental school now, and very much similar to what we spoke about today. And that's where it started. It started with 2 doctors, and then it expanded now to double the size. About 5 years ago, we relocated the center and renovated the center, so now it's a brand new facility.
And what kinds of patients do you treat at the center specifically?
Patients, primarily developmental disabilities, and that's our primary cause. So autism, Down syndrome, cerebral palsy, other genetic disorders, and so on. So we've got that population.
The geriatric population too.
Exactly, which is a huge population, and especially here in New Jersey, that's a population that really is not being seen very much. We also see the psychiatric population, and the one thing that I think you had mentioned it, right, was the forensic the forensic psychiatric population as well, which also, is very often an underserved, very difficult population to try to find care. So we're seeing many of them too.
And what makes the facilities at the center different from a typical dental clinic in terms of equipment or physical layout?
Well, I'll tell you, from my perspective, there isn't really that much of a difference in terms of the facility itself. We have 9 operatories. Of those 9 operatories, probably the biggest difference between us and any other type of facility is that we have 2 operatories that have no dental chair. So that way you can fit in a stretcher, you can fit in a patient who's in a wheelchair who's unable to transfer from the wheelchair to a dental chair. We work with a behind-the-patient delivery system as opposed to most dental offices which work with an over-the-patient system. We have overhead lights that are pretty much out of the way of the patient grabbing them or something along those lines as well.
We also have wall-mounted radiographic units. We also have a Nomad system that we can use, which is an X-ray unit that's handheld in case we need to get into any difficult areas. We have access to that.
Yeah, I think there are 2 very important points. One is that, aside from the facility itself being wheelchair accessible and otherwise accessible, which is fairly Americans with Disabilities Act compliant, there's that. But the reality is that most dental offices which do have that should be able to accommodate the majority of patients otherwise, because there really isn't that much of a difference in terms of dental armamentarium, dental equipment, dental supplies, and so on. But the other thing that we do have that really is tremendously valuable for us is we're close to the hospital. And about 1/2 of the new patients that we're seeing every month require care in a hospital setting. And so we need to have that type of facility available.
Okay, and in terms of training and the people on staff at the center, what other experience do they bring to the table that enables them to more effectively treat this population?
So in my case, what I did was I did a 2-year general practice residency program right after I graduated. And my first year was in oral medicine. My second year was a general practice residency year just in special care by itself. And so from that, I was able to use that training to go ahead and translate that into the career that I have today, working in the special needs population in terms of dentistry. And we have that at the school where we offer a 2nd-year residency program that's geared towards special needs training.
And the real necessity is for that first-year general practice residency training, because it gives you the hospital background, it gives you a background in working with patients with far more complex medical conditions, far more medications, a whole different scope of practice than you would necessarily get as a dental student.
And the dental students at the Rutgers School of Dental Medicine, how are they incorporated into this center?
So they rotate for 1 week with us. So every 4th-year student rotates with us for 1 week, and that gives them, first of all, an experience with the patient, so it alleviates a lot of the fear and anxiety that maybe there might be with that population. And also gives them more access to working with those of us that really see this population on a routine basis. And it really allows them to kind of change their way of looking at the patients, change their way of thinking about how we're going to approach patient management and patient care as well. There are also selective elective courses. So Dr. Ballesteros is one of the directors of this selective elective course. And there are several other lectures that they get over the course of the 4 years. So there really are a lot of areas of incorporation. We also are able to incorporate in the pediatric dentistry residents, the postgraduate students there, and the general practice residents. They also rotate, clinically through our curriculum as well.
And particularly, what kinds of oral health needs are you seeing among these patients that are unique or different from what general dentists might see in their day-to-day practice?
Not so much different as maybe a bit more pronounced.
Okay.
I would say it's probably...
I would say the other thing that we see too is we see patients who are sicker, who have a lot more medical complexities that have to be managed in order for us to do the type of treatment that we need to do, whether it's bringing a patient chairside clinically or bringing him to the operating room to go ahead and do a full mouth dental rehabilitation. So, one of the things that is a challenge to us is patients are getting older and they present more significant medical challenges as they age up. And so we try to mitigate those factors by consulting with physicians, specialists, and whatnot to optimize a patient for treatment.
So we see, for example, patients with epilepsy. So very often, a person coming into a routine dental office who has a history of epilepsy may get a seizure once every now and again. We may see patients who have seizure disorders where they're getting seizures several times a week, even several times a day. We'll have diabetic patients who may have diabetes even as a result of their primary condition, but the diabetes is more out of control. We'll see patients taking lists of medications that are tremendously long, so the complications from those medications, the adverse effects, are a significant issue as well. Scoliosis becomes a tremendous issue. So, for example, a lot of our patients who are wheelchair bound, there are aspiration issues and other airway control issues. So those are things that you probably wouldn't see much in general practice too. And what that does is that leads to many of our patients requiring a lot more collaboration and coordination with the medical side and the dental side, as opposed to just being able to treat the patient routinely the way you would do it in a regular practice.
And what role is sedation and anesthesia playing in a lot of this treatment? Does this population require more of it? Are there extra measures taken when in that care?
I think tremendously, and I think that depends a lot on which population you're talking about within special care, because it's not a monolithic population. It's very much a broad-based spectrum. So. We'll use oral anxiolytics, and so the medications are really able to help to relax a patient, kind of calm them down, let them get some sort of treatment, or even if it's some sort of examination as opposed to getting a full boat of treatment. Like I said, about 50% of the new patients that we see are patients that need to go under general anesthesia and be completely sedated, if they're going to get any sort of appropriate care. So it really runs the entire gamut. We're also able to work with the other specialties of the dental school as well, and in some cases they'll consider sedation for the patients as well. Okay,
and recently I think the ADA has mandated special needs dentistry as part of the curriculum requirements beginning in 2020. How is the Rutgers Dental School incorporating that, or are you doing a lot of that already?
I would say we're doing a lot of it now. I think what changed was the language. The language changed from was it to be managed? Assessment to manage, which is it's a key change, because instead of just students now, being required just to assess a patient with special care, now the change in code is that they have to be able to treat patients with special needs. And I think that's one of the things that we do that was ahead of the curve, is a lot of the students that come and rotate through our clinic are actually treating patients, providing care, and actually learning how to manage and assess patients as they come in through our doors.
Right. And I don't know how many years back it goes, but it goes back several, where the mandate had gone from there being no mandate for special needs at all to there being a mandate for the students being able to graduate and be competent in the assessment of this patient population. Now it's gone to the management of this patient population, which includes obviously direct dental care, but even for those patients who cannot actually receive care, knowing what to do with that patient. Where is the patient appropriately managed? Is it going to be by a physician, by a dentist, by a specialist in a hospital type setting? So it really is it's a tremendous step up, and it means a great deal, not just for the patients that we're seeing, but really for the practitioners and how they're going to be addressing those patients in the future.
Okay, and while this change in the curriculum will help dental students ongoing, many dentists who are already practicing and have been practicing for years, if not decades, what do they need to know? Because they're missing out on these new standards and teachings.
Yeah, I mean, in some cases, well, I will say this. You know, in any dental school, you're taught the basics of anatomy, of physiology, of pharmacology, all the basics that you need. If you go ahead and you've done a residency, which I guess about 40% or 50% of the population may have done, then they've also gotten an advanced look at this. You know, so they already have a lot of the information. A lot of it's a question more of looking at how the patient needs to be addressed and how you look at the problems of the patient. So we were talking earlier on about the issue of a diagnosis first kind of concept, where you look at the diagnosis and develop the dental treatment plan as a reaction to that. And that's really very important. It's taking the knowledge that you have, because dentists know about epilepsy, they know about diabetes, they know about cognitive and developmental disabilities in general, but it's a question of taking all of those facts, bringing them together, and then being able to address that appropriately. So that's where I think that the code change probably makes the biggest impact on that, because now it's a question of how do we actually manage the patient, not just let's evaluate the patient and figure out from there what's happening, but now we actually have to manage this patient.
Okay, and do you have any other advice for dentists who are going to be seeing more patients with these kinds of needs in the future? As you said in your presentation, that the population is simply growing. People are getting older, they're surviving longer, it's being diagnosed better, and just there are more people in the world. So what advice do you have for dentists who are going to be encountering these patients more often in the future?
Take your time, reach out to people who do this at the schools or at the hospitals. I guess just do the best you can.
I mean, I think definitely, like Dr. Ballesteros is saying, be patient is number one and take your time. And that's something that's harder and harder nowadays, throughout medicine, but it's extraordinarily important. The second is really to approach the patient from a diagnosis first perspective, not just of the tooth, but the entire patient, overall. And beyond that, recognize that there's really no way of us not caring for this population. This is a population that, like you're saying, has grown by leaps and bounds. The profession nowadays, the students that we're seeing are going to be in practice 20 years, 30 years, even 40 years from this point. That population isn't going anywhere. That population is going to be here, it's going to grow, and the need is there for continuing education. So keep up with what's going on, make sure that you get an education even beyond dental school, and make sure that you're incorporating these patients into your practice, because like anything else, the more that you do, the better you're going to get at it.
Okay, great. Well, thank you for sharing your expertise and your time with us today, and good luck. Thank you.
Thank you. My pleasure.